Okay, I think we're all set to start our webinar this evening. I'm Winslow Idicula. I'll be the moderator for this session, and we thank you for joining us this evening to come and talk to us about pediatric OSA beyond the TNA. And imagine this: you've been what you thought was the final boss. The music gets louder, the credits start to roll, and then you get, oh no, a new game unlocked. The enemies are tougher, the patterns are different, and suddenly the victory doesn't feel so final after all. That's a lot how we approach pediatric obstructive sleep apnea. For years, we were thinking adenotonsillectomy has been our final boss, a definitive high success intervention. And most of the time it works, but not always. Because for a subset of patients, the game doesn't end there, right? The snoring persists, the apneas linger, the daytime symptoms creep back in, and it's not a failure, it's just a different level with a different set of mechanics. Today, we're going to press continue and explore what happens after the boss battle, why obstructive sleep apnea continues. So these are our Taos Spring webinar speakers, or you can think of them as our players tonight. Our first one is Dr. Chorney. He's an associate professor at UT Southwestern. He's completed his fellowship training at Children's Hospital of Philadelphia and earned certification in complex pediatric otolaryngology in 2022. He serves on the editorial board of Laryngoscope Investigative Otolaryngology and has a specialized clinical focus in pediatric airway disorders and pediatric airway reconstruction. It's an honor to have him with us this evening and to share his expertise and knowledge. Our next player is Dr. Solis. He is a pediatric otolaryngologist at Driscoll Children's Hospital with specialized expertise in craniofacial surgery and cleft lip and palate care. He completed advanced fellowship training at Vanderbilt University and is recognized for his dedication to caring for children with complex craniofacial needs. We are honored to have him with us and grateful for the opportunity to learn from his expertise this evening as well. And Dr. Kothari is our other player. He's the founder and leader of Pediatric Sleep Specialists, where he has built a comprehensive care model dedicated to helping patients sleep better and live better. Passionate about caring for children, he's inspired by their resilience and committed to empowering families through knowledge and support. He also takes great pride in mentoring trainees and seeing the lasting impact of compassionate care on their children and their families. It is a privilege to welcome him today and to learn from his experience and insight as well. So we're going to have Dr. Kothari go first, and we'll have him share his slides.
All right. Thank you. Thanks for having me, everybody. So my name is Roberto Kothari. I'm a pediatrician, a pediatric pulmonologist, and a sleep medicine physician. As Winslow mentioned, I am the medical director of Pediatric Sleep Specialists. We are a comprehensive pediatric sleep disorders program and are rapidly growing. I am the owner of Pediatric Sleep Specialists, which provides clinical pediatric sleep medicine services. We've started to expand and add other specialties as well as a research division. However, these activities aren't related to the content of this presentation. So today, I'd like to provide a pediatric obstructive sleep apnea primer, go over mechanisms of obstructive sleep apnea in children, and then I'll pass it on to the rest of the panel. And then we'll come back and review some of the non-surgical treatment options for obstructive sleep apnea in children, followed by how other sleep disorders might affect the management of obstructive sleep apnea in children. So pediatric obstructive sleep apnea is characterized by intermittent and prolonged, at times, complete or partial obstructions in airflow during sleep that can result in gas exchange abnormalities or hypoxemia, and it can also be associated with sleep disruption. So you guys can see here, obstructive events can be a complete absence of airflow. So there's no airflow in the thermistor signal, and these are obstructive apneas. That's how we categorize them. Sometimes there are periods of obstructed airflow where there's a partial absence of airflow. So there's still some air entering, but just not enough. And we call those obstructive hypopneas. You can see here that when these occur in a series, they tend to be associated with hypoxemia.
Dr. Kothari, just sorry to interrupt. I don't think is anyone else seeing the slides advance?
I can see his slides advance, but
Yeah,
I'm
I
not sure
can
if everybody
too.
else
Just
can.
making sure it was just me. Apologies.
Can you guys hear me okay? Okay. All right. So do you see OSA, AASM diagnostic criteria? Okay, perfect. So the American Academy of Sleep Medicine diagnostic criteria for OSA is the presence of one or more of any of the following signs or symptoms. And I won't read those out just for the sake of time. And then in addition to that, the patient must have either one or both of the following PSG findings. I will read those out. So at least one obstructive apnea per hour, or a mixed apnea or hypopnea. So any one of those three event types should occur at least one time per hour, and or a pattern of obstructive hypoventilation defined as at least 25% of the total sleep time with the presence of hypercapnia in association with any of the other following recorded findings. And of course, the symptoms must not be better explained by another current sleep or medical disorder, medication, or substance use. So, of course, while obstructive sleep apnea in humans is not quite as common as cephalic airway obstruction syndrome in English bulldogs, it's still highly prevalent. So we know that about 30 million adults in the United States are estimated to be affected by obstructive sleep apnea. And the prevalence is on the rise for children. So a little over a decade ago, about 3 to 9% of children were estimated to have obstructive sleep apnea in the United States, whereas more recent reports suggest up to 20%. And habitual snoring prevalence is even higher, up to 27%. There is a bimodal peak. So children ages 2 to 8 years often have obstructive sleep apnea in association with adenotonsillar hypertrophy, and then occurs again another peak in adolescence and often associated with obesity. And then there are those kind of differences between boys and girls after puberty. African American children are affected by obstructive sleep apnea about 4 to 6 times more compared to children of Caucasian origin. History of prematurity confers significant risk, so about 3 to 5-fold increased risk, and this seems to be related to anatomy. And then if you have a first-degree relative, that also confers significant risk. So if obstructive sleep apnea is suspected, what's the next step? According to the, it's in presentation mode, wouldn't be a problem. Sorry, guys. So I apologize. On Teams, I don't have to have this like little green box. But basically, the American Academy of Pediatrics has a clinical practice guideline for the diagnosis and management of childhood obstructive sleep apnea syndrome. And their recommendation is to obtain a polysomnogram, and this is based on high quality evidence. So if you suspect obstructive sleep apnea in a child, the recommendation is to obtain a polysomnogram. Whereas based on lower quality evidence, the recommendation to refer to an otolaryngologist or a sleep specialist is simply just an option. And the basis of that is we know that symptoms, physical exam, and laboratory tests don't predict polysomnography findings in children. We also know that clinical parameters don't differentiate obstructive sleep apnea from primary snoring. And we also know that important exam findings like tonsil size and Frieden palate position don't predict AHI severity. And so those are some kind of important rationale for ordering a sleep study if you suspect obstructive sleep apnea in a child. It also helps to determine if a child is best suited in an inpatient or outpatient setting post-surgically. It can help identify patients who are at risk of postoperative complications and identifies patients at risk of residual obstructive sleep apnea. Now, the American Academy of Otolaryngology has a similar stance regarding ordering polysomnography before adenotonsillectomy, however, with some asterisks. So they recommend, AAO recommends PSG prior to adenotonsillectomy if the patient has any one of these conditions, or if the need for surgery is uncertain, or if there's a discordance between consular size on physical exam and what's being reported clinically, essentially what the caregiver is observing. So what does polysomnography entail? So these children are wired. We place all these sensors on the scalp, on the face, chest, legs, fingers, sometimes toes, to collect all of this information, okay? And this is all kind of sort of dictated by our American Academy of Sleep Medicine scoring manual that tells us exactly where to place these sensors and channel settings kind of down to very specific recommendations. And importantly, we score these events based on pediatric scoring rules. When the recommendation for polysomnography post-adeno tonsillectomy comes from the American Academy of Pediatrics. So the AAO doesn't have a very clear guidance on this, but these are some of the reasons that you would perform a polysomnography post-adeno tonsillectomy. And given that we are kind of addressing a larger audience here, I know there are a lot of practice. There's a lot of practice variation from community to community. So I just wanted to point out that the American Academy of Sleep Medicine advises against the use of home sleep apnea testing in children. And the rationale for that is that there are various home sleep apnea testing technologies. However, none of them have really been robustly validated against the gold standard, which is polysomnography. So there are studies for certain kind of more commonly used devices that show sometimes overestimation of disease severity, and then in other instances, underestimation in disease severity. And then not to mention, none of these tools allow for continuous carbon dioxide monitoring, which is a recommended tool that's used in polysomnography in children. So when considering the pathogenesis of obstructive sleep apnea, it's important to kind of consider the changes in respiratory physiology during sleep, even in healthy subjects, even in those who don't have obstructive sleep apnea. So we know that when we go to sleep, those of us who are healthy sleepers have an increase in upper airway resistance during sleep. And that's due to reduced airway diameter, often most likely explained by pharyngeal dilator relaxation. We also know that those of us who are healthy sleepers have a decrease in nocturnal ventilation, and that's largely related to our loss of our wakefulness drive to breathe. Okay, so a decrease in our central respiratory drive. And it seems straightforward, right? It seems like, okay, well, if the airway is just a little more narrow in patients who have obstructive sleep apnea, or if there's just enough, other anatomical factors, whether there are soft tissue factors around the airway, or whether there are craniofacial factors, that's enough to sort of tip the scale. And that's what some of the old schematics of obstructive sleep apnea always placed an emphasis on, and rightfully so. We know that the critical closing pressure of the airway is sort of an important pathophysiologic concept of how obstructive sleep apnea occurs. We know that the pharynx has a collapsible kind of portion of the tube has sort of a rigid kind of proximal and distal portion, and that sort of creates a Starling resistor environment. We know that for air to flow through this Starling resistor, we know that the upstream pressure, so pressure kind of in the nasal cavity upstream or proximal to the collapsible segment of the airway, must be greater than the pressure around the airway, or the critical closing pressure, and also greater than the downstream pressure. So we know if there's kind of this higher upstream pressure, lower downstream pressure, and less forces around the airway that promote collapse, there's going to be nice airway patency and normal airflow. However, if any one of those variables changes, it either tends to promote toward partial collapse or complete collapse. So if even when the upstream pressure is greater than the pressure and the forces around the collapsible segment of the airway, a low downstream pressure can result in at least partial airflow obstruction. We also know that whenever the pressure around the airway is greater than either of the other two pressures, that will then result in complete airway occlusion. So this is kind of a core pathophysiologic concept place an emphasis on, and how we have kind of come up with various targeted therapies for patients with obstructive sleep apnea. We're very focused on that sort of upstream segment of the pharynx, right? We want everything to be nice and patent and clear, proximal to that collapsible segment of the airway. We also know that we want to work on, weight management strategies, anything that will reduce some of those pressure forces in the area around the collapsible segment of the tube. However, we're discovering that people have obstructive sleep apnea for different reasons. This is a very heterogeneous disorder. And so in the recent years, there's been a lot of emerging evidence that it's not as simple as keeping the airway nice and patent and open. There are other sort of endotypes that can contribute to airflow obstruction during sleep. And we're going to quickly review those before I pass it on to the next speaker. So we reviewed the critical closing pressure of the airway, but there's also something called a low arousal threshold. You can see here these green bars. So you have and these purple horizontal bars. So these purple horizontal bars show airflow obstruction through the upper respiratory tract. And these green bars are showing you how much inspiratory effort occurs after the airflow obstruction occurs that then triggers an arousal. So there are some patients who seem to have generally some degree of airway patency, but when it comes to just like anatomically, right? You look in the back of their throat, even on DICE, things might seem patent, and it doesn't really add up with what we're seeing on our sleep study or the patient's symptoms. And what we see in these patients is they're more prone to arousing from that respiratory effort that occurs after an airflow obstruction event during sleep. And this is in comparison to patients who really don't experience that, and they have a higher arousal threshold. Another OSA endotype is something called a high loop gain, and I think that's sort of made a lot of press, if you will, in the medical literature in the recent years, and including in the otolaryngology literature. Basically, the respiratory system is composed of a ventilatory controller, right? We have our brainstem where our central chemoreceptors are, and those sort of are kind of sampling our carbon dioxide levels, and our carbon dioxide becomes kind of the primary driver of respiration when we're asleep. So those of us who have a stable ventilatory controller, whenever we have a breathing disturbance, our response to that disturbance is kind of controlled. So, we might have a brief moment of airflow obstruction, but then our response to that is a very small increase in respiratory effort, followed by maintenance of airway patency. Whereas patients with a high loop gain, those of us who have kind of an over-exaggerated response to airflow obstruction, sort of have this really kind of big respiratory effort after we have an airflow obstruction event. And as a result, we breathe off carbon dioxide. And so when our brainstem is trying to sense whether it's time to breathe or not, it thinks, oh, carbon dioxide levels are low. I don't need to trigger those pharyngeal dilators to open up and allow for a breath to pass. And as a result, we have an airflow obstruction event. And another endotype is something called poor muscle responsiveness, and it's exactly what it sounds like. There are some people who have, in response to increased resistance in the upper airway, they are able to activate their upper airway muscles, whereas others don't have that same level of muscle activation. A lot of this has been studied in adults, and now there's kind of more research going into this in pediatrics. So there's actually this something called the Children's Adenotonsillectomy Trial. It's one of the largest trials, multi-center sort of randomized controlled trials in pediatric obstructive sleep apnea, which Dr. Chorney is going to review. And there's sort of a repository of all the polysomnography data from that study. And now researchers are going back into that data and kind of sort of studying the polysomnography data to see if there are endotypes that they can assign to the various children who are in that trial. and all sorts of interesting findings. But basically, the summary of it is that there seems to be a lot of heterogeneity in children who have obstructive sleep apnea, where some of those OSA endotypes seem to come up, basically. So, any questions about that? We can, you guys can pop questions into the chat, but I know I took up a lot of time. We can pop it, kind of pass it on to the next speaker.
Yeah,
Okay.
thank you, Dr. Kothari. Appreciate it. I guess, Dr. Chorney, if you want to share your slides, we'll go with you.
Okay, great. All right. So, I'm going to talk a little bit about the otolaryngology perspective of persistent sleep apnea after adenotonsillectomy, the sort of OSA beyond TNA. But we'll talk a little bit about TNA in general, what we think we know about it. This is my disclosure. I do some educational consultation for Smith and Nephew. Briefly, I'm going to talk about what we think we know about TNA and its role in resolving obstructive sleep apnea in children. And then to start to explore a little bit about what our academy has provided as guidance for otolaryngologists when it comes to management of persistent OSA, including sleep endoscopy. I'll briefly touch a little bit on what the role more recently is when it comes to the utilization of hypoglossal nerve stimulators in children with trisomy 21. And then at the end, we'll talk about cases and after all of us had a chance to present. And so I think any good conversation about pediatric sleep apnea and the role of adenotonsillectomy really requires a reflection on the childhood adenotonsillectomy trial, the CHAT trial, which, anytime you get an article into the New England Journal of Medicine from an otolaryngologist perspective, you should pause and make sure you feel pretty comfortable with the evidence in there. And this slide sort of goes over who were the children in the CHAT trial. These were children who were between 5 and 9, had been randomized to either an early TNA within a few weeks or watchful waiting. And that group of children were then followed for 7 months. And the primary endpoint was attention and executive function that were measured objectively at the initial portion of the trial and then at 7 months. And the secondary outcomes, including behavior, symptomatology from both the caregivers, their teachers, quality of life, and then, of course, a post-operative or a post-interval sleep study. The median AHI in this group was about 5. So these kids were sort of on the moderate sleep apnea quality. And what this trial showed that the primary endpoint was no different between the children that were randomized to having been receiving an early tonsillectomy or those that were observed for 7 months. However, things like quality of life, patient or family caregiver reported behavior and symptoms, as well as PSG outcomes, were all improved in the group that ended up having had an adenotonsillectomy. And so this started to show that beyond waiting, that you could improve a number of key patient-related factors by offering adenotonsillectomy in this group of children. In the group of children that were obese, that were Black race, or had a higher AHI, the resolution results of these things tended to be less. And that makes sense. We've seen other studies that show that, but it's important to highlight that this group was a particularly vulnerable group of children within the trial who were less likely to have the same benefit of adenotonsillectomy. But there's some important considerations to think about in this trial. First, of all of the children that were enrolled or were considered candidates by the otolaryngologist for this trial, over half of them actually had a normal sleep study. And in fact, those group of children under an AHI of 2 were excluded from this trial as they were considered to not have a threshold of OSA on their PSG that met criteria to be enrolled. But it's important to note that even though they were considered candidates from their symptomatology perspective, their PSG data did not show anything more than perhaps an AHI of 2. And in that group, the majority of children who had a sleep study that were enrolled, mild sleep apnea was shown, so up to the level of 5 events an hour. And that key to this, and this table, the figure there shows this, is that rate of resolution, even without surgery, approached 46 to 47%, meaning that if you just watched children for 7 months and repeated the sleep study, that metrics on their polysomnography would improve with nothing other than an interval of time. However, having intervened with a adenotonsillectomy, that rate of resolution did increase. But again, it's important as we talk about what to do when it comes to children who have sleep apnea with or symptoms with or without objective evidence of PSG data that's showing an AHI greater than 2. That these children will continue to improve if you watch them too. So there's some thought that this can translate when we talk later on about what to do about the children who have persistent sleep apnea post-operatively after TNA. And then the second trial that I think is important to talk about, which is a more recent paper, that is the PATCH trial. And this trial tries to look at a little bit of a different phenotype of children, which is those that have more mild sleep apnea. The age group was a little bit wider, 3 to 12 years of age. And again, a similar approach. They were randomized, either getting an adenotonsillectomy or to be observed for in this trial a period of 12 months. Again, primarily looking at executive function and attention, but a number of secondary objectives, including quality of life, PSG data, and this also included blood pressure as another metric, and interestingly as well. And much like the CHAT study, the primary endpoint, we'll talk about that in a second, was no different between groups. But as I mentioned, this is a different group than the CHAT children. These children were a little bit younger, tended to have a little bit more mild disease. Many of them didn't even have an AHI greater than 1. And it really helps us try to frame the management algorithm when it comes to children who maybe have sleep disordered breathing or snoring, along with a constellation of symptoms, but don't have that moderate or severe evidence of sleep apnea on a sleep study. And so, as I mentioned, the primary endpoint, which was executive function or attention, did not change between the group of children at 12 months who had an adenotonsillectomy or those who were observed. But there's more to it, which were improved behavior, lower burden of symptoms, improved quality of life, sleepiness, and progression of OSA on post-operative or post-interval sleep study was improved. So when we take these two things together and we start to think a little bit about what to do for the children who have been refractory to sleep or to adenotonsillectomy and have sleep apnea, this trial suggests that TNA cannot reasonably always improve. Neurocognitive testing, which was the primary endpoint of these trials, was not different between the group of children who were observed or who had an adenotonsillectomy, but symptoms, including quality of life, behavior, definitely did improve much more frequently in the group of children who had an adenotonsillectomy, and that even in the mild group of children, that symptoms should be the driver for management decisions, not just the AHI alone. And so, shifting a bit now to the post-TNA management algorithm, and I'll just sort of say, in general, that this is tricky. There is no doubt that there is a wider range of interventions and outcomes and diagnostic approaches that these children can follow a different pathway than our sort of comfort with just offering an adenotonsillectomy up front. And so this is a common challenge. Maybe about 20 to 30% of children could have this. The awake exam in the office sometimes misses that. And so that's where the role for a flexible sleep endoscopy or a drug-induced sleep endoscopy can be helpful, because it can be a way to identify where that obstruction occurs and helps to guide management. And our academy suggests that this is really valuable in the children who have persistent OSA after TNA. It can be considered in children who have OSA with small tonsils or prior to an addition surgery, and maybe it's a bit less useful in children with very low AHI. But I think we're seeing more and more clinicians be comfortable with considering the role for DICE primarily in that bolded one, which is the group of children who have OSA after having had an adenotonsillectomy. And we'll talk about this later this evening when we come to some of these cases. There's some protocol points. I won't sort of belabor the details, but we want to make sure we're taking good documentation with video and photos. We want to make sure that we're offering a jaw thrust to see what role that may play in the obstruction or the relief of the obstruction. Going below the level of the glottis can be helpful at times, but not always. And then we want to avoid things like supplemental oxygen and routine decongestants at the approach. And most folks will use things like either dexmedetomidine or propofol, and then to titrate that so that we're mimicking obstructive events in sleep without being over sedated, where they're then leading to be needing to be given interventions like oxygen or positive pressure. And then, of course, talking with our anesthesiologists, this is something that many of them are very familiar with, and each of them have a recognition of their role in achieving that adequate level of sedation for them. And then, our academy more recently published a consensus that sort of provided some perspective on how to manage these children, or consider managing these children after having had an anatonsillectomy but continue to have OSA. Now, this, we'll talk about in a moment, is really a dynamic between symptoms and PSG findings. There's not really a clear cutoff for where that line is, and I think it depends a little bit on the child. So symptoms and shared decision making is tremendously important for these group of children. And of course, if you have the ability to do so, I would strongly encourage a multidisciplinary approach. I think it's really valuable to get the perspective of our pulmonology and sleep medicine colleagues when it comes to the approach for caring for these children. And so, as I mentioned, how do we define it? The consensus really struggled with this. They said it's either greater than 1 event an hour with symptoms or greater than 5 without symptoms. I think really the symptoms are the key here. We'll talk about it later on. Snoring, restlessness, weight troubles, fatigue, behavior. These are things that we shouldn't ignore. And as I mentioned in those 2 trials, those are an important metric with which we should rely upon. But the numbers themselves can sometimes be a little misleading and may be something that we have some flexibility in, depending whether or not the symptomatology is present there too. And we'll talk about that a little bit later on. So what to do about it? Mild asymptomatic children, you could observe them maybe in an interval sleep study after a period of time. The role for medical management, nasal steroids, Singulair, CPAP, and I'll talk about this a little bit. And then weight management. We know that children who are obese or have severe obesity struggle with this, and we shouldn't withhold from them the management outside of diet and exercise, but we should still make sure that that's a part of our multidisciplinary approach, including nutrition when necessary. And this list is really not supposed to be something to memorize, but these are the things to think about. Is it the base of tongue or the lingual tonsils? Could it be the turbinates? If they have state-dependent laryngomalacia or sleep-dependent laryngomalacia, could it be a supraglotoplasty? Expansion pharyngoplasty, and we'll talk about craniofacial procedures. And of course, tracheostomy should always be in the back of our mind, depending on the severity of the sleep apnea. I mean, that is certainly an approach to the right child, and can be an important improvement in their quality of life, despite the life-changing intervention it may be for them. And then, of course, using our sleep endoscopy as a way to help identify and approach these different procedures. And then finally, before I wrap up here for my part, we have started to utilize the hypoglossal nerve stimulator in children, which has been around for a number of years, of course, in our adult sleep medicine and practice. I think, of course, right now it is primarily for the children with trisomy 21 and persistent severe sleep apnea, have had a TNA, intolerant of CPAP. There's the FDA-approved range, which I include on this slide, for children between 13 and 18 with an AHI range like that. But I'll just start to say that increasingly, the off-label use in select patients has started to grow. And so you might be able to find perhaps a late teen who doesn't have trisomy 21, or maybe a little bit of a younger trisomy 1 child who more and more as time goes on and the evidence continues to be published, which is on the precipice of being shown, that we may start to see this procedure creep into our management for children who have had a TNA and continue to have sleep apnea. And again, this sort of highlights some of what we think we know or what we've seen so far in the utilization of this in our trisomy 21 population, that the reduction of AHI is significant. Many prove over 50% improvement in the PSG results after having the nerve stimulator placed. But the quality of life and the symptomatology, again, I bold that here because that's an important part of this. We do see evidence that has been a tremendous improvement for these children, and that their ability to utilize the stimulator has increased. So ultimately, this is not going to be a primary approach, but in selected children, and currently right now it's trisomy 21, but that might change as time goes on, can be an important, effective adjunct to consider. And so with that, I will stop sharing my screen and turn it back over. Thank you.
Thank you, Dr. Chorney. I appreciate it. And we'll let Dr. Solis go next.
Thank you, Dr. Chorney. That was a great presentation. I hope to carry from that in terms of not only thinking about soft tissue work, but also considering the facial skeleton as targets of OSA in the select patient. I trained at two programs that had a strong emphasis on craniofacial care, and now being in the Rio Grande Valley, an area of 1.4 million people, I find that being an otolaryngologist provides a unique perspective on some of our most complex patients. I have no disclosures, and this is a newborn kid that you probably will be consulted on in the NICU for a small jaw, but that's not always the case. They may be teetering along and may end up in your clinic as a referral for obstructive events. And from the profile view, you can see this patient has significant micrognathia and associated rectognathia. And how should we approach such patient? The most common thing when we think of craniofacial and infancy, and it's pure band sequence where most of the time we think they have a cleft palate, but that's about 90% of the time. It's a micrognathia that's pushing the tongue back and causing an glossoptosis and airway obstruction. And this is an impressive view of an oral exam of a patient that looks at the tongue posteriorly displaced, looking almost like an epiglottis, just to demonstrate how severe this could be. And should we be getting sleep studies on infants? This is a challenging question, and most of the plastics literature does focus on surgery directed by sleep studies. But I think it's resource intensive, and not all institutions offer it in patient setting. And also, there's not a lot of data, but there's small papers that look at healthy infants. And if you get them in within a first month, they're all going to show severe sleep apnea, which is an important consideration for these patients and whether that drives decision making. This is another prospective study that looked at 1 month versus 5 months, and patients are going from severe to mild sleep apnea. And again, these are healthy kids with no sleep disorder breathing symptoms. So then when do we actually end up operating? And a lot of this comes down to how we feel comfortable as otolaryngologists assessing airways, and are they requiring respiratory support? Are they having cyanotic episodes? Are they, when they're supine or they're feeding, they're having issues? And dysphagia, there's growing evidence that with surgery, like a mandibular distraction for Bureau-Ban or small jaws or retrognathia, that we can avoid G-tubes in many patients that have significant airway anomalies. And this is a representation, a 3D representation of what we're trying to achieve with mandibular distraction, and that it's not a cosmetic procedure. We're overcorrecting the jaw to relieve that airway obstruction. And virtual surgical planning is a really nice tool to help guide your osteotomies, your cutting guides, your distracting devices to create cuts that are patient specific and to avoid follicles and the nerve. This is an intraop image that looks at that osteotomy with the distraction device in place and the nerve nicely delineated there. And it's quite impressive how much you can distract, about 1 to 2 millimeters per day, to achieve a jaw that many families are quite surprised about. But at the end of the day, they're going home mostly without any respiratory support and definitely without a tracheostomy. This is a recent patient of mine that pre-surgery and post-surgery, just how much of a physical difference that mandibular distraction can make. In terms of systematic reviews, looking at PSGs after interventions like mandibular distraction, most kids do have resolution of their severe sleep apnea, and most kids do end up leaving the hospital without tracheostomy. So it's a nice intervention to offer in the toolbox for children that are infants, but also even older kids that around the 1 to 4 years of age that have anywhere from 1 centimeter of retrognathia to more severe, and that can be guided by DICE, which Dr. Chorney was demonstrating. And obviously, there's a host of craniofacial conditions. We take care of these patients with trisomy 21 quite often in our clinic, and while they have mid-face hypoplasia, they have a host of other issues such as hypotonia or soft tissue that ends up becoming a multifactorial issue. Patients with craniofacial conditions can have quite significant facial skeletal aberrations affecting their respiratory drive, and also children with conditions like trichorrhea that may have the mid-face issues, but also TMJ issues that may not allow for us to perform mandibular distractions, and tracheostomies end up being their best option. And so, as the rest of our speakers have mentioned, it really takes a multidisciplinary disciplinary approach and evaluation to determine what's best for these patients. Oftentimes, it's not one option, but various options, and assessing it through a different lens as an otolaryngologist, and and thinking about the skeleton as well as the soft tissue is important. Now, sometimes we cannot avoid tracheostomies, and that should always be part of our conversation. But a child that has a tracheostomy at birth at some point may be a candidate for secondary sleep surgery or even facial skeleton work that can hopefully get them decannulated. This is a patient that I had met that received his care in California with a hemifacial microsomia and was tracheostomized since infancy for glossoptosis. Now, at 6 years of age, the family met me and was hoping for other options, thinking that maybe it's the jaw, as many surgeons were telling him and the family. And so I performed a drug-induced sleep endoscopy and found that he had multi-level airway soft tissue narrowing that can be addressed with time. And so the adenoids were quite enlarged. The tonsils, while this is a still image, were nearly touching during inspiration. And the base of tongue was mostly filled with lingual tonsils and not so much the glossoptosis. And so while you may see a patient that looks like their facial skeleton is the issue or their jaw is the issue, drug-induced sleep endoscopy does end up becoming a great tool to assess other targets that may be patient-specific. So in this patient, we first performed an adenotonsillectomy, and then we staged a lingual tonsillectomy to avoid a concentric scarring. And ultimately, the patient does have a high arched palate and quite narrow with a posterior crossbite on that hemifacial side. And we have referred him to our orthodontist colleagues for consideration of rapid maxillary expansion, which I'm going to touch about later, as a great adjunct. And then after all these interventions, we are now pending a cap sleep study, which we think we can decannulate without having to address the jaw, and can be a more timely fashion in a future stage. So rapid maxillary expansion really has gained popularity over the last decade, especially in our dental colleagues who are more sleep focused. And the way it works is that it's a device fashioned by an orthodontist that applies pressure laterally and pushes the upper jaw out about 0.5 millimeter per day until achieving a appropriate palatable arch length. And once that's in place, they have a waiting period for anywhere from 3 to 6 months. And it has to be done pre-puberty because there is a suture line that runs through the palate that they're really using to their benefit to create this new osteogenesis. And this is a meta-analysis that looks at expansion outcomes in children that had high arch palates or narrow palates. Most kids had undergone a prior tonsillectomy. And you can see here the pre-AHI was in the moderate range and went down to mild. And the SpO2 nadir also improved from 87 to 96%. And the key takeaway here is that this was a good adjunct to consider for patients with small tonsils or prior tonsillectomy adenoidectomy. And a key consideration are patients that are younger than their teenage years, that have narrow palates and posterior crossbites. And the thought is that it improves nasal patency. And so while it's not a home run intervention, I think it's a great tool to offer patients that have multifactorial issues to their sleep apnea. And so as otolaryngologists, we have quite an array of tools now that we're slowly learning about and getting stronger evidence for. And it's important to see these patients through a different lens. And I think the key takeaway from our talks today is that while the tonsillectomy and adenoidectomy has been touted as the gold standard for a long time, it's really important to evaluate these patients more comprehensively in a multidisciplinary fashion. Thank you.
Thank you, Dr. Solis. We appreciate it. And we're going to go back to Dr. Kothari.
All right, so I'm going to quickly cover the medical management of persistent obstructive sleep apnea post-adenotonsillectomy. So in 2023, the American Academy of Otolaryngology published a consensus statement kind of coming up with recommendations for surgical management for persistent OSA post-TNA, medical management, and then several months later, the American Thoracic Society published a practice guideline kind of reviewing their recommendations. And so they both had similar recommendations. This is from the AAO, but again, similar recommendations. The American Thoracic Society placed a greater emphasis on weight management, weight loss for children with persistent disease post-TNA, but aside from that, mostly similar. So I'll just read them off here. So in children with persistent obstructive sleep apnea and surgically modifiable sites of obstruction, surgery or a trial of CPAP are both reasonable options. It says that auto-titrating positive airway pressure is a useful therapy in select children with persistent disease who are awaiting a CPAP titration or further surgical management. And then it covers that steroids are effective, safe and effective for patients with mild or moderate persistent OSA and nasal obstruction. Montelukast is an effective treatment for children with mild to moderate, again, disease and symptoms of sleep disordered breathing. And CPAP is a reasonable treatment option for children with obesity and persistent OSA. And then watchful waiting is also reasonable for children who have asymptomatic disease and fall into that mild category. So, you know, all of these sort of treatments I'm going to briefly cover that were in that table, they're all generally addressing, you know, kind of sort of clearing the airway, right? Ensuring that there's adequate upstream flow that's greater than the pressure forces around the airway and greater than the pressure downstream. So that's exactly what CPAP does, right? It's splinting the oral pharyngeal airway. It's the most common non-surgical treatment of obstructive sleep apnea in children. The studies show that the primary endpoints of reducing the apnea-hypopnea index in the sleep lab, consolidating sleep, and improving daytime symptoms have been shown in patients, in children who use CPAP chronically at home. We know that prolonged use of the same mask may alter facial structure, so we know that there can be some potential mid-phase hypoplasia with the use, especially of a nasal mask in younger children. So this is always something that's on our radar. We think it probably helps that, especially younger children, they're rapidly growing, and as a result, we're having to refit them for new masks, and that then results in contact at different sites on the face, which we think may mitigate some of this. We also will sometimes alternate between nasal masks and nasal pillows, and that again will put less pressure on that mid-face structure. The literature shows that adherence to therapy is challenging. Meta-analyses show that about 50% of children who are prescribed CPAP are actually adherent to therapy. What's often published in the literature is consistent with our experience that proper mask fitting, actually performing a positive pressure titration to identify the correct pressure that controls the disease helps, and then behavioral support, so desensitization. So I'll just kind of briefly, so desensitization essentially is helping the child feel like this is something they could do, and helping the family feel like this is something they can support their child through. So we tend to do that before the patient's ever exposed to the pressure sensation, before they ever have titration, come in for an overnight titration. And we feel that that helps. So we bring them into our CPAP desensitization clinic. We fit them to the mask. We show them how easy it is to remove the headgear and the mask. We then have them coach nasal breathing with their mouth closed. And we then turn on the CPAP at a very low pressure and then gradually increase it while we're coaching their respirations. And oftentimes we'll even shut the lights off and give them an opportunity to nap. And that initial exposure makes them feel like that's pretty easy. It's not how my dad struggled with it or how an uncle or grandparent struggled with it. So it's just making it feel on the intranasal steroids. Again, this is shown to help in children who have mild or moderate persistent obstructive sleep apnea post-adenotonsillectomy. The child does not have to have comorbid allergic rhinitis. This and actually this can work even before surgery. We know that some studies show that even use of intranasal steroids for 6 weeks can have several months of benefit after a period of washout, as shown on polysomnography. So the polysomnography indices that improve in that initial period post-therapy have been shown to retain that improvement as far as a year out. The European Respiratory Society actually recommends that after doing a short course of intranasal steroids for this disease, we should repeat the polysomnography 12 weeks later, and I agree. So leukotriene modifiers, so montelukast. We know there's some studies that show that there's kind of sort of a receptor response in the upper airway. This therapy works for children who have mild to moderate persistent OSA post-adenotonsillectomy. Same thing, short courses can work and have persistent benefit for an extended period. Obviously, this works best in children who don't fall into that overweight or obese range BMI. Also tends to work in toddlers and school-age children compared to adolescents. Similar recommendation from the European Respiratory Society. There is a black box warning. If we feel that this is the right therapy for the patient, we sort of work through that with the family. So there are the real specific, the next part of the talk for me was kind of just how other sleep disorders can kind of muddy the picture, right? They can, when you're trying to make a surgical decision or when we're trying to make a medical decision for persistent disease, how much of the clinical symptoms that the child has are due to another sleep disorder and not sleep-related breathing disorder like obstructive sleep apnea. So when the family is reporting to you all or to us that the child has these very specific respiratory signs during sleep, it's really compelling that the focus needs to be the breathing. But there are times where they're not so specific, right? And they're in your clinic saying, little Timmy's still waking up or still really restless during sleep or having lots of daytime symptoms, getting a lot of complaints from school, academic performance issues, and so on. And so when we're faced with that, again, the emphasis is kind of sort of a multidisciplinary approach to that child's care. So just as an example, we know there's this entity called COMISA. So we know that insomnia is highly comorbid with obstructive sleep apnea. And we don't expect, our non-surgical teams, we know that you guys are really busy and may not have the, and you're very focused on the anatomy and you may not have, some of the expertise or time to really evaluate for some of the other common sleep disorders. So again, I think it's helpful if non-surgical sleep specialists like us can be involved in the child's care. But briefly, if a child has problems falling asleep or staying asleep or wakes up earlier than natural at least 3 times a week for 3 months, in addition to some other criteria, those are the diagnostic criteria for chronic insomnia. It's highly prevalent. We estimate that about 40 to 50% of kids under the age of 5 meet the diagnostic criteria. So if that's not treated, the family is going to be coming to you more often than not, and saying, hey, we had surgery and a lot of these other symptoms have persisted. So while you're trying to kind of weigh and make a decision on whether the next step is a revision adenoidectomy or a DICE or another surgical procedure, I think it's helpful for a pediatric sleep medicine person like me to kind of weigh in to see if there's one of these other problems playing a role.
Perfect. Thank you. Thank our speakers. We really appreciate you giving us your expertise on all these. Now that we have all the answers, we are going to do some case presentations and we'll kind of go through those together. And we'll kind of do 1 to 2. I think we had 5 total, but with time constraints, we'll probably do a couple here. Okay. I'll share my slides here. All right. Can you guys see this slide?
Yes.
Perfect. And so we'll kind of have our speakers chime in, and we'll kind of start with the first case here. Let's see. All right. So this is a 5-year-old healthy child, status post adenotonsillectomy. This child has persistent snoring, restless sleep, occasional night awakenings, no significant daytime behavioral concerns by the parents, but on examination, you see mild inferior turbinate hypertrophy, no craniofacial abnormalities. Your sleep study comes back and it's mild obstructive sleep apnea 3.2 with minimal desaturations. So what's our next step? How do you counsel these parents and patients on a sleep study and symptoms? Dr. Kothari, what do you think?
Well, I mean, mild disease. The patient's quite symptomatic. We know restless sleep during sleep is really nonspecific. So a sleep-related breathing disorder can do it. Insomnia can do it. So I would want to know, does the child have comorbid chronic insomnia? And if we were to treat that with something like cognitive behavioral therapy for insomnia, that's sort of a lower risk, easy access treatment option? That might be one of the things I would want to know.
Yeah, good questions. And then Dr. Chorney and Dr. Solis, what do you think about this child?
Yeah, I mean, I think I take a step back and I try to determine, is this something that's just strictly based on some objective data points on a sleep study, or are there things that bring the child and the parents to me that suggest that they are identifying concerns? And again, the subjective symptomatology we talked about there suggests that, okay, doing something is probably worthwhile to try to improve that. How aggressive to be? As we mentioned, the objective metrics suggest that the sleep apnea is mild, but that doesn't mean that we shouldn't be willing to offer intervention. And so my thought would be to start on the medical therapy approach. It sounds like perhaps maybe this is a nasal dilemma. Could we treat with intranasal medications, treat allergies, and see if we can get a medical response first? And then I would see them back usually in a couple of months, get a sense of whether that's improved subjectively. If it has, great. If it hasn't, then should we look a little bit more to the structure of the nose, nasal cavity, nasopharynx? And that's where things like a repeat nasal pharyngeal X-ray might be valuable. Is there a role for turbinate reduction if they've failed medical management? That's how I would approach it. But I think doing something is worthwhile based on the symptomatology.
Yeah, I agree with Dr. Chorney. I mean, it all depends on how the family perceives this, and it doesn't seem like the child is being impacted during the day. So I would favor the more medical therapy route. And I know there's some otolaryngologists that don't prescribe Montelukast, but I do commonly prescribe it in my practice for short term and counsel on those black box warnings. And then I will see the patient back in 6 to 8 weeks to reassess. I'll do fluticasone and Montelukast, and depends on the response, then how conservative or aggressive I will be. If I ever do a DICE on a mild OSA patient, I will be a lot more conservative in terms of the more, you know, like expansion pharyngoplasty versus, epiglottopexy, like those type of interventions that carry a little bit more risk.
Perfect. Thank you, guys. We'll go on to the next case here. let's do this 10-year-old with a BMI greater than 95th percentile, status was adenotonsillectomy. Common kid that we kind of are starting to see in our patient population. Ongoing snoring, daytime fatigue, difficulty with concentrating at school. Obese on your examination, minimal residual adenoid tissue that you're seeing, unremarkable airway, but his AHI is 10 with minimal desaturations. What's our next step for in treatment for this patient, you think? Some first line approaches. Dr. Solis, do you want to start off with this one?
Yeah, I mean, was that unremarkable airway eval nasopharyngoscopy or flexible laryngoscopy in clinic?
That's correct.
Yeah, I assess the family. I always give them the option of medical therapy like CPAP versus secondary sleep surgery. Um, weight loss is always a great option, but the adherence to a weight loss program and dietary plan is very challenging, especially in South Texas. So that's not something that I really bet on. I do offer diets for these patients because sometimes you will find secondary lesions that can potentially benefit. And if you can improve some of the sleep apnea or the HI, then they may be on a safer level that has less cardiopulmonary risk. And if they can't tolerate a CPAP, which adherence is about a 50-50, then at least it's not posing a long-term health consequence to them.
And do y'all ever, for your older kids, do you ever send them for bariatric surgery? Are you getting an endocrinologist involved for GLP-1s? What are y'all's opinions on those?
Yes, to the
Yes.
endocrine referral.
Great. Alrighty, guys, let's go on to we'll go on to the last one just because we're running short on time. Which is kind of craniofacial kids that we can look at. So this is a 7-year-old girl with 2Q, 37 deletion status was adenotonsillectomy. Otherwise healthy, persistent daytime and nighttime symptoms, underwent a supraglottoplasty, revision adenoidectomy, followed by a lingual tonsillectomy. So continues to have severe obstructive sleep apnea with a nadir of 81%. These are your DICE findings. So almost near complete tongue base obstruction, secondary to glossoptosis and mild residual lingual tonsillar tissue that is regrown. And then you notice 1 centimeter of micrognathia. What are kind of some more options there?
Well, I'll start by, these kids are tricky. That first off, anything you do that requires anesthesia is not an inconsequential ask for these children. And many of them have had multiple rounds of anesthesia. And so when you come back to the parents of these kids, I would imagine a conversation about trying to offer another intervention could be met with some trepidation and uncertainty. I think that's very reasonable, especially because these are procedures as you start to explore that are associated with a little less certainty, right? Yes, it might be nice to try to address this nice little still photo here from the base of tongue, but the likelihood of success is, of course, not 100%, and comes with it perhaps an involved and challenging recovery for those kids. And so I do think this is where the multidisciplinary approach needs to be really really explored in depth, including our pulmonary and sleep medicine colleagues, because before we start to be trapped into a surgical decision, I think we should be really trying to vet every single modality we have on our armamentarium. That's my approach on this. I don't know what you guys think.
Yeah, I totally agree with you, Dr. Chorney. After you've undergone 3 rounds of surgery, it's really hard for anyone to believe that they're going to achieve success through surgery. And I mean, the gold standard is CPAP therapy, and if they can tolerate that, great. And so then it becomes a challenge in terms of offering a family a more aggressive surgery, splitting the jaw. advancing that jaw forward and believing it's going to happen. Now, there is data that shows that you can achieve success with amandibular distraction even in older children, and it has to be a very thoughtful discussion with the family before you embark on such a big surgery on a older kid that's no longer an infant and does carry risk of dental malocclusion and losing teeth and numbness. But it depends on how much this child is impacted with exhausting all medical therapies.
Perfect. And then Dr. Kothari, if you're looking at CPAP for this kid, is this a difficult kid to fit, or how does this work with your PRS kids?
Yes, absolutely. There aren't, now there are these 3D printers where you could do really unique things and really customize the mask interface for children with significant craniofacial asymmetry. So yes, we potentially could find a mask that works for this child. Obviously, nasal pillows and over the nose mask also can do the job, and then we can work on leaks and such. But I just think of, thinking of our audience, I do think of, gosh, we have such workforce shortages. There aren't a lot of pediatric pulmonologists and sleep medicine doctors available throughout the state. But I think a child like this is likely to be seen at a tertiary care a pediatric facility where some of us do exist. So no, we have patients just like this, similar age group, similar anatomy, and they thrive with positive airway pressure. Yeah. They tend to have those complete obstructions, so we prefer that over something like supplemental oxygen.
Well, no, we really appreciate that. This is sounds like this child may be undergoing bilateral mandibular distraction, to see if that will help as well. And I would say it looks like our time is running low tonight, and we really appreciate everyone attending here. I really appreciate Dr. Chorney, Dr. Solis, and Dr. Kothari for taking the time and giving us their expertise on these topics.